Hello, everybody. My name is Caroline Lafferty from Cycle Against Suicide. I'd like to welcome you all here tonight. We're just taking a moment to let others join the webinar here. I take this opportunity to introduce Professor Fiona McNicholas and thank her for joining with us. Tonight, Fiona is going to discuss understanding post-traumatic stress in children and teenagers. It's part of the development of our health programme, which we are working with UCD to help support parents and teachers. Fiona?
Caroline, are you ready?
Yep, we can hear you, Fiona.
Lovely. Am I ready to go?
You are ready to go.
Great. Welcome, everybody, and thank you very much for joining us tonight. I would just like to start by letting you know what my objective is of tonight's webinar. The main thing really is to distinguish between normal stress and trauma that occurs in children. And my hope is by being aware of and understanding childhood trauma, that parents may be better equipped to support and protect their children, and indeed to seek clinical services when that is necessary. Parents can provide children with the necessary tools to recover, grow, and thrive, and even after difficult experiences. Lastly, I want to remind people that the management of childhood trauma is very important because it prevents later adult mental and physical illnesses, and to remember that parents who have been children themselves may experience both current traumas and also past stress or trauma, which may be triggered by the experiences their own children have and may certainly contribute to parenting stresses. So in general, this is the overview of the next hour I'm going to spend with you, talking about stress and trauma, moving on to PTSD and complex PTSD, and then bringing to your attention adverse childhood experiences and the salience they play by way of preventative work. Lastly, I will end by talking about treatment rationale. So stress is the body's normal experience to a challenge, threat, or indeed excitement. From an evolutionary point of view, it allowed natural selection and promotion of the species. The animal that was able to run the fastest, or the person that was able to hide in the cave, was more likely to survive than the person that wasn't. Stress serves as a protective function or a warning system that helps us fight or escape, and that's very important. The brain is hardwired evolutionary. It's prepared for certain things that were dangerous. If you think about it, you place a small little toy that looks long and squiggly like a snake in front of a little 6-month-old or a 1-year-old, and the baby will instantly recoil from it. And this is based on the inbuilt fear of snakes. Similarly, strangers are to be feared initially until the baby or the young person is able to recognize that they are not as dangerous as they feared. But that doesn't kick in until the first 6 months of life, because in the beginning, an infant needs to connect with a person, whether a stranger or not, in order to survive and thrive. These simulations will elicit automatic fears in young children. However, when you place in front of young children much more dangerous objects like guns or tanks, there is no immediate automatic fear response. So the events that cause these stressful reactions are known as stressors. And what's happening at a physiological level? So the first thing is when the individual sees something that is threatening, noradrenaline, that's a chemical in the body, is released from our sympathetic nervous system. That increases our heart rate, our respiratory rate, our eye pupils are dilated, and our sweat glands are activated. Cortisol is released from the adrenal gland, from the brain, and this allows an uptake of glucose. It breaks down carbohydrates and fats so they're ready for immediate use, and it suppresses inflammation. Blood goes from the stomach and the skin to the heart and the brain, and indeed the muscles, and this allows us to get ready for that immediate survival of either fight or flight. At a brain level, what's happening? There are 3 parts of the brain that have been considered. The first is the reptilian brain, and this is the oldest brain in the most primitive of life. It's also referred to as the lizard brain, And in humans, it involves the brainstem and the cerebellum. And all our automatic functions occur here, like breathing, like our heart rate. And when a threat happens, the reptilian brain is stimulated and immediately starts kicking off even before we have a conscious awareness of what is happening. The mammalian brain then is the second higher order brain, and this involves the limbic system, which involves emotions, memories, habits, and our attachment pattern. And I will talk in a moment about the amygdala and the hippocampus, which are both part of this middle brain. And lastly, the higher order brain, our cortex and our prefrontal cortex, which is unique to humans and which has allowed humans to far advance beyond animals, even though we are much smaller than animals, because it allows us to have complex thinking, to develop language, to have abstract thought, imagination, and consciousness. So typically what happens, for example, any of you out there who's afraid of a spider, when we see our spider, our amygdala in our limbic system, in our mammalian brain, sets out an alert. It seeks information from the hippocampus and the cortex in order to decide how dangerous that threat is and how the body needs to react. If it's an extreme stress, the reaction can be automatic before the connection is made to our emotional brain and indeed our thinking brain. And in fact, the amygdala shuts off the connection between the cortex. So there is no rational thinking. The response may be completely automatic, even if it's a dangerous response. And our memories are not processed or accessed. If we are overstimulated, our amygdala can be on constant alert and set out false alarms. And sometimes we are pre-programmed to certain stimuli, built evolutionary, as I suggested in the beginning, by way of snakes. Maybe something bad happens, some of us, by way of spiders, or in individuals who have been exposed to trauma. So an easy way might be to think of it as the amygdala, which is that little red central part there. It's like a smoke detector. It signals dangers and it invokes the immediate response, evacuation from the house if that's necessary. The amygdala is immediately active post-birth. And under typical situations which are not too extreme, it's linking with the hippocampus, which is involved in our memories. It's asking our memory bank to say, have I seen this threat before? Is this a dangerous threat? How should I approach it? Am I okay to wait around and problem solve it? Or should I immediately evacuate the building? It also links with the prefrontal cortex for a reasoned, rational response. And indeed, in order to start kicking in some problem solving. If I need to evacuate, what's a safe way to do it? Do I need to remember to bring other people with me? Do I need to remember to bring my telephone or money in case I'm going to be out for a while? That's under normal conditions. However, sometimes the sympathetic nervous system, if it's not able to react by fighting or flighting, what it does is it invokes the parasympathetic system and allows us to freeze, or in some cases, dissociate. And just some simple examples there. In an everyday situation under minor stresses, a child who isn't able to tackle their maths homework or tackle the stress and put in coping strategies might feel so overwhelmed by it that they end up doing nothing. They put off dealing with the stressful situation, or later on they will think that they might finish the task. They're unable to make decisions because their cortex isn't working. They may go blank because their language system, their language part of the brain is not properly connected with the rest of their brain, or they may shut down completely. What happens when the alarm is too faulty? Whilst we appreciate the correct signaling of a smoke detector to run out of the building, or if we perceive a bear in the forest to prepare to run away, but if that alarm is going off, even when somebody comes into the room who's wearing a furry jacket, If somebody comes into the classroom who reminds you of somebody who has been threatening to you in the past, if a smell of something invokes a very traumatic memory, it's unhelpful if that amygdala is on alert all the time, because a brain that is stressed is not able to concentrate and focus on the task at hand. It is constantly scanning the environment and looking for threats. So, whilst initially frequent alarms to keep us on alert might be helpful by way of preparedness and lead to some resistance to ongoing stressors, when that happens over an extended period of time, we are unable to withstand additional stressors and we're unable to fight other infections. It doesn't allow us focus on normal everyday life, and it doesn't allow us to get out there and live with our friends and our family. It can lead to complete exhaustion with the depletion of all our resources, and our cortisol levels remain high constantly, and that is associated with not only subsequent mental health difficulties, but also physical health difficulties like autoimmune illness, autoinflammatory conditions like rheumatoid arthritis, chronic myalgia, chronic fatigue, and indeed cancer and early death. So take, for example, a child who has been bullied at school by particular perpetrators. When they see a group of other peers approaching them that are in a little bit ambiguous, they may instinctively react on account of a pre-programmed amygdala with a faulty hippocampus that has not processed memories properly. They react to those peers approaching by running away or by fighting them, rather than waiting and engaging and seeing whether these are social friends, social peers who want to connect with them. The teacher may witness this and may describe the child as a dysregulated child or an aggressive youth, and disciplinary action may follow that interaction, rather than an understanding that the child, in fact, is reacting to some internal threat. They are in a panic-like situation. They are not fully in control of their emotions or their thinking. And rather than sanctioning or disciplining them, what they need is a calm understanding and a reassurance. And certainly the treatment response or the approach by both the peers and the teachers would be different. Going back to the concept of stress, stress is not always bad, and in fact it is a necessary part for us to develop as individuals and to master autonomy and independence. So some stress is referred to as positive stress, when we feel excited or when we have mastered a challenge, or the level of stress may be high enough to motivate us to do something and to get something accomplished. Tolerable stress is stress that typically is not normative. It is threatening, but it may be something like a family member's death or a serious illness in ourselves or in another, or in responding to a natural disaster. It is tolerable because the person has a supportive relationship that allows the child the ability to cope with the stress, either independently or with the additional support of the carer. However, toxic stress refers to a situation where there is an absence of that social support, be it peers or more typically from family members, or where the level of stress is too high that it overwhelms the person and paralyzes them. And it certainly leads to significant impairment in learning, in behavior, in relationships, and in longer-term physical and mental health. The Yerkes-Dodson law suggests that it is best in certain situations to have a small amount of stress that motivates us to activity. Think, for example, you're doing a piano lesson. If you're too chilled out about it, you do no practice, you go in on the day, and you're not particularly careful. If you're overstressed about it and too perfectionistic and set too high expectations of yourself, you are far too stressed and nervous on the day, you make many mistakes, and you don't do yourself justice. So there's a sweet spot in the middle where you have just the right amount of stress that activates you and allows you after the event to actually succeed and feel resilient, and that builds on further successes. You will be familiar with these as causes of stresses, both external stresses, but also internal. And in fact, some people would argue that we are our own worst critics, both as adults and as children. We are the ones who typically find the most fault in ourselves. Some of the external causes are other people expecting too much of you, like your parents or your teachers or your friends, a sudden unexpected loss or change, having to be in a social situation where you don't feel comfortable, like children having to meet new children in school or going to a new social event or joining a new club. Big changes in the family, like moving house or a new family member coming in, or parents separating and a new reconstituted family. And the internal stressors, setting too high standards, being a perfectionist, being a pessimist, having the glass half full all the time, working too hard or trying too hard, not managing their time well, or unreasonable beliefs like I won't be liked if I'm not the best. I won't be liked if I'm not the thinnest. I won't be liked if I'm not the smartest. And these are some of the symptoms of stress that will be familiar to you. Physical symptoms, appetite, headache, sleeplessness, trouble breathing, particularly in the acute parts of stress, feeling your heart beat quite loudly, and feeling sweaty, dizzy, and panic attacks. And what's interesting is that even in the face of an initial threat, animals are able to pick up our bodily responses to threat on account of the smells that we emit from our sweat glands. Psychological symptoms of stress, which might be less obvious, are feeling angry and irritable, impatient, intolerant, not being able to concentrate, or we may cope with our stressors by intake of alcohol, caffeine, nicotine, or other substances. And of course, sometimes psychological symptoms are when we feel overwhelmed and helpless, and where we might feel dissociated or disconnected. It's important to remember that different people respond to and manage the same stressor differently. And that depends on a number of factors. The child's developmental age, whether this happens as a primary school or secondary school, what coping strategies they use and have used in the past, successful or not. But most importantly is the degree of support they have with family, friends, teachers, and others. And the factors of the stressor that contribute to whether a child will be overwhelmed or not are the duration and the intensity of the stressor, their past experience to it, and the number of stresses that are occurring at any one time. When faced with a stress situation, the child needs to cognitively appraise that. And if they are primary school children, it's very helpful if the parents can help them, because younger children will have difficulty thinking about thinking. And so parents can model that for them. So the first step when faced with a stressor is to say, is this a good or a bad one? Like, for example, am I being invited to a party and I'm really stressed about it? We'd see that that's a good stress. Whereas, is it that I have just been expelled from school or rejected from the hockey team that I was playing with? That might be seen as a negative stress. The second thing the child has to ask themselves is, can I cope with the stress? So in the situation where it's a positive stress about going to a party, if they can cope, that's great. If they can't cope, then you start invoking coping strategies. Normally, our first response is to elicit the support of others. Our second response is the automatic symptomatic nervous system arousal. And the last response then is the parasympathetic response where we freeze. So general guidelines for managing stress are to think about having a low stress environment for your child at school and at home. And this is based on social support, anticipating specific stressors and learning how to tackle them. Very important not to take away the stress from your child, or not to be the helicopter mom, or a new expression is the lawnmower parent, where you make sure you get all the stresses out of the way of the child so they don't have to experience any. That is not helpful. The best time your child can be exposed to stress and even fail is at home when other supportive environments are there, because they'll be able to pick themselves up afterwards and succeed at the next event. And that failing and succeeding later is very important so that they're not worried about failure. It's important we appreciate failure is not a problem. Not trying is the problem, and being so afraid of failure that we don't do anything becomes a problem. So anticipate and discuss the stress with your own child and help them navigate through it. Children will typically use two types of coping strategies. The first one is the problem solving. It's also called offensive, where they say, right, what's the problem? How am I going to approach this? What are the different ideas I might have, or solutions or pathways? Try one out. How did that work? If it succeeded, great, use that again. If it didn't work, what went wrong? Or maybe try another one, evaluate it, and then clap yourself on the back when that has worked well. So that's the offensive or the problem-solving way. Another way that adolescents can cope with stress is emotional focused, and that's called defensive. And whilst this might be good initially for a while, it's not as good or as helpful as problem solving. And that's where a child might say, let's say they weren't invited to the party or they weren't with the in-group, they might say, oh, well, I didn't really mind, I didn't really like that group anymore. So you reduce the emotional salience that you have placed on the stress. Let's say you failed an exam at maths, so it doesn't really matter. It was never my best subject. I'll just move on to liking English, or I'll go on to pass maths. And then just lastly, for the general principles, it's paying attention to other factors, managing stress by way of attention to emotional and physical health, healthy eating, healthy dieting, getting enough bed rest, avoiding excess substances, caffeine, and other toxic substances for the body, and really avoiding too much social media use. Spiritual help and being part of faith group can also, and has been shown in research, to be very helpful. By way of building resilience in children, always empower your children as opposed to disempowering them. Continue to maintain high expectations, but not too high. If you set the bar too low, your child then doesn't challenge themselves and doesn't expose themselves to the possibility of trying that bit harder. Check the young person's assumptions, observe and question, and do that in a Socratic way. I wonder what you thought about that. I wonder what you thought when that happened, as opposed to you giving your opinions first rather than eliciting the opinions of your young person. Be a relationship coach. Life is quite tricky for young children and adolescents because they are such socially driven animals. We all are, but particularly in adolescence, that's really who they want to hang out with. And sometimes that is difficult. So practicing that at home, role-playing it at home, helping them with it can be very helpful for them. Guided opportunities for helpful participation in other activities, charitable events, school events, helping other people can be very helpful for self-esteem. And providing them with unconditional support. And this is really, really important. Traumatized children later on say, all I wanted was to be known, to be seen, to be heard. So even before children experience or exposed to trauma, on an ongoing basis, provide that unconditional support for your child. I want to now move on, and I hope I'm not going too quickly. I can't see any comments or anything, which is probably just as well. But I'm going to move on now to the concept of trauma, which is different from that normative stress that I have discussed with you. So while stress is response to a challenging or a new life event, like exams, deadlines, school transitions, losses, relationships, home life, social media, they're usually once-off and manageable. Trauma, on the other hand, is quite different, and it's an experience of extreme shock, distress for the young person. And complex trauma refers to a condition of prolonged distress where the child feels trapped, helpless, overpowered, or overwhelmed. While stress is not always harmful and should not always be avoided or protective against, trauma is nearly always. Both acute stress disorder and post-traumatic stress disorder can occur after trauma, and the difference really lies in the way they develop and how long they last. Acute stress disorder occurs very quickly in relation to the disorder, traumatic event, and is usually short-lived. The definition used by the US Substance Abuse and Mental Health Service Administration in the US is very helpful to consider for trauma. And they refer to trauma resulting from an event, a series of events, or a set of circumstances that is experienced by an individual as harmful or life-threatening. It's unique to the individual, and it can cause lasting adverse effects, limiting the person's ability to function and achieve mental, physical, social, emotional, or social well-being. What's very important to remember is it's the experience of the event rather than exposure to the event that is traumatic or causes trauma. So the different types of trauma, it can be single, multiple, it can be acute trauma, a once-off, or it can be complex, occurring over time. There can also be historical or generational trauma, which is a constellation of characteristics associated with massive cumulative group trauma across generations. And we are now recognizing that trauma can actually have an effect on our genes. It's referred to as epigenetic changes. It may change the way our genes are presented physically by adding on extra bits to genes, or it may turn on or turn off some of the genes that we have in our coding. And those epigenetic changes are actually passed down from one generation to the other, priming the next generation for vulnerability to trauma. And if you think very, very sadly at the moment, the exposure of the world to conflict, to war, to hostage situations, to school shootings, all of these traumatic events that are happening to children, adolescents, and adults are having a cumulative effect on our society that we have to consider how this is going to play out, and we have to advocate much more strongly to stop it. In terms of the impact of trauma, it is different for different people, as it is with stress. So for children, what's very important, the trauma may follow an event that adults might not have thought was so severe, but because children lack perspective or life experiences, or because cognitively they may not be able to understand or verbalize what's happening as much, what might seem a more trivial traumatic event may actually lead to significant trauma in a child. Similarly, different people may relate to the same event differently. Take, for example, a road traffic accident, and you have two individuals involved in the same accident, involved in the same injury. One person looks at that and says, I had a lucky escape. I have some injuries, but they're relatively minor rather than death. And another person responds to that trauma by saying they were so unlucky to be involved. They're devastated by the personal injury that they carry, and they go forward limiting their travel, maybe limiting their wish to go in a car, limiting their interactions with other people as a result of that. And later on, I will explain to you how some of those individual reactions are affected by both vulnerabilities within the child, within the event itself, and within the environment. So these are some of the more serious events that might lead to trauma, as opposed to the other stressors that I discussed with you, which are more or less normative by way of the prevalence with which they occur. But as stated, trauma is becoming much more prevalent than it should be. So these events are also becoming much more common. So it's exposure of the young person either directly or indirectly to serious events that actually or potentially threatens their safety or that of a loved one. For example, assault, abuse, war, conflict, displacement, medical trauma by way of medical procedures that a young person might have to have, having a physical illness or injury. In our professional capacity, teachers, care workers, clinicians may be exposed to trauma, or first responders, social workers, police, ambulance men, policemen. Children may be exposed to trauma by persistent bullying and significant bullying, and that's very important to consider contributing to post-traumatic stress disorder. Parental violence may also be traumatic. Widespread media coverage of traumatic events now might pose traumatic experiences for young children, particularly if they are not in safe, secure environments. The typical types of trauma that have been collected in a lot of the research would refer to the presence of abuse, whether it's physical, sexual, emotional abuse, the presence of physical or emotional neglect, or the presence of family discord, families being incarcerated, a family member having a substance misuse, or witnessing domestic violence within a family. The experience of trauma within the brain, the emotional response leads to, as a result of a deeply distressing or disturbing event, triggers a fear response in the amygdala in the same way a stressor does. However, the child may feel powerless, shocked, or disconnected from reality on account of the extent of the event. They shut off the connection between their hippocampus. They're unable to process the memories correctly and to store them correctly, or to retrieve other memories that might provide more safety for them. And they also shut off the connection with the higher order thinking that allows them to put words on the experiences that they are having, and also to consider problem solving. What we know from looking at the brains of young children who have been, or adults who have been exposed to trauma, is the amygdala is hyper-aroused, it is larger in volume, and that the connections, the nerve connections between the limbic system and the cortex have been reduced as a result of chronic trauma. A child is unable to emotionally digest the trauma or to understand what has happened to them. So these are some of the research that has been done with it. What they have found is that the right side of this smoke alarm, called the amygdala, in the mammalian part of the brain, like that mammals have, the level of activity that you see on MRI functioning, the more activity that is there is linked with hyperarousal states in the PTSD group. And we see decreased functioning in other parts of the brain that connect to the frontal cortex. These are some of the psychological symptoms and physical symptoms that are linked with trauma. What's important to remember is behavioral changes, because obviously when children are in school and they have sudden behavioral changes, it's very important that we don't assume it's due to naughty behavior, oppositional behavior. And we shouldn't assume, like, if you're not concentrating in class and you're very disruptive, and you're very hyperactive and you're very impulsive and you're taking risks, all of that fit along a diagnosis of ADHD. But the difference with ADHD is it's something that happens developmentally over time. You typically don't have new onset ADHD symptoms. And so when there's any change in a young person's behavior, it's very important to stop and ask oneself, has anything happened to trigger that change in behavior? The opposite may happen also, where the child is suddenly shut down. They feel helpless, dissociated, not in contact with people. They may have an emotional numbness or a blunting. But what often happens, but may not be apparent, is the child takes on a huge sense of blame and guilt or shame for what has happened. In some way, they have been led to believe that it was my fault that the trauma happened to me, I must not be a good person. And that sometimes changes their interaction with others, where they spend their time trying to appease and please other people, even to their own detriment. Many physical symptoms happen, and these are all as a result of initially the sympathetic overdrive, which we discussed in the acute stress response. That's great for fight or flight, but it's not when you have to sit still and continue to try and learn in school or continue to try and interact with peers. So some of the theories as to what happens to children when they experience trauma. One of them is a shattered assumption theory. And that's because that children start off in life, and this happens from the parent as they're growing up, when the baby and the toddler is constantly told by yourselves as parents, you are the nicest little boy in town, you are such a lovely girl, you are so good at doing all of this. They take it for granted that they are good and that the world is good and the world is safe and benevolent. But what happens when a traumatic event happens to them, it shatters that assumptions. And from then on, the child can carry with them a belief that the world is unsafe and dangerous. And then they react to that world, losing trust in the world, failing to develop trustful relationships with others. The psychodynamic perspective is that early life trauma disrupts essential formation of trust, and that's necessary for any subsequent relationship. And it leads to continued unconscious mistrust of other people, and that needs to be explored in order for the individual, typically in adult life, to be able to form healthy, happy relationships. And lastly is the behavioral theory, which is that there is a learned response. A child learns that they are abused and that is what they have to expect, and it becomes a conditioned fear. And I'm not sure if many of you are familiar with experiments that were done many years ago, would not be allowed to be done today, which was done on dogs by a psychologist called Seligman. And what he did was he put dogs in a cage and locked them and gave them electric shocks. And the dog desperately tried to escape in the beginning, and after a while realized it was pointless. They were helpless, so they no longer tried to escape. And then even when the gate was open and the dog was exposed to the potential of a shock, the dog did not escape. And if you think of what happens in terms of Stockholm syndrome, when people are abused by, they're held captive and abused, or abused by their parents, even when escape is possible, they are too scared to escape. I'm going to move on and just talk about the concept of PTSD briefly, and just to remind ourselves that this started, initially people became aware after World War I that an event could cause long-lasting effects on individuals. It was referred initially to shell shock, and they felt it was only if you were in close proximity to the explosives. And later on, they realized that other soldiers who weren't that close also had shell shock. So they recognized that even if you weren't directly involved in a traumatic event, you could still be indirectly very traumatized by it. After World War II, the concept of shell shock was replaced by combat stress reaction or battle fatigue, on account of the fact that soldiers, and most of them were just young 18, 19, 20-year-olds, were just so traumatized by war they couldn't continue. The reaction at the time was to ban that concept because they needed soldiers to go to war and to treat them with medication so that it blunted their emotions. And it was only after the return of the veterans in the US that the concept of a need to help veterans return to life and to cope with the stressors that they had experienced became known as a stress reaction, and later on in 1980 as post-traumatic stress disorder. In 2013, we have the concept of post-traumatic stress disorder being removed from an anxiety disorder and linked more with a stress disorder, which was felt to be important because it placed the response more on the event and the experience of an event, rather than some vulnerability within the individual. And the symptoms are just three with regard to the ICD, which is what we use in the European countries. The first is that the child or the adult will re-experience the traumatic event in the form of intrusive memories, flashbacks, nightmares. A child may retell the story over and over again, or may draw pictures in school, or may act out playful situations of the bullying or the abuse that has happened. The second thing is avoidance of reminders of the traumatic event. And this might be avoidance of if the traumatic event happened in a particular place, they won't go to that place. Or if the abuser, for example, was smelt of a certain aftershave, that they will avoid going to places where there is that strong smell. If the traumatic event happened on a bus, a child may stop going to public transport or taking public transport. And the last one is persistent sense of threat, where the child or young adult is hyper alert, hyper vigilant. So if there is a car that backfires, the child will suddenly jump up. If there's loud music or the dogs bark, you will see the child suddenly jumping up. These symptoms must last for several weeks, and they must cause significant impairment. The event must have been extremely threatening or a horrific event, with the understanding that for children, this may be different to what adults would perceive as potentially threatening. The concept of PTSD, which was really developed by a psychiatrist in the States called Bessel van der Kolk with others, understood the reality that children are exposed to abuse over periods of time. And this constant re-exposure to abuse led to a sense of complete powerlessness for the child. And that should be considered separate to the diagnosis of PTSD. And they introduced the concept of complex PTSD, which regrettably was not included in the American diagnostic classification system, but has been included in the European system. And in addition to those three salient features of re-experiencing it, avoiding it, and being on hyper alert, it also includes affective dysregulation, where a child or a young adult will have difficulty calming down or regulating their emotions, where they have this terrible sense of worthlessness and low self-esteem, and where they have difficulties in relationships with others, with their peers, with teachers, with people in authority. The events are prolonged, repetitive, from which there is little escape, often secondary to child abuse, but can also be secondary to repeated bullying in school or on social media. It is incessant and it never stops. There is very little protection that the child can get from it. The child often reacts by learning. Their inner person who is dysregulated and has difficulty controlling their emotions, they feel too nervous to expose that to the world. So they put a shell of numbness or appeasing others on the outside. They want to figure out how other people feel they should react, and they try and react accordingly. And their inner self, their true, authentic self, at the center of that core is often not recognized. And treatment requires the child to be allowed to go to that person, their inner self, and behave and react and live in a way that fits with that, rather than what they feel others are demanding of them. So, towards the end, looking at risk and protective factors for trauma, and this can involve characteristic of the individual, the traumatic event, and the environment. And just like with stressors, the child's age and stage of development, previous exposure, their level of intelligence, their strengths and vulnerabilities, individual cultural understanding. So in your culture, if there is a slightly misogynist approach, it can be very hard for young girls to be able to cope with traumatic experiences that they have had. And neurodevelopmental difficulties, individuals with neurodiversity, ASD, ADHD, can often have difficulty dealing with trauma, and research is now finding that they're also more likely to be exposed to trauma. To give you a little bit of an idea by way of the characteristics of the traumatic event, obviously things like the frequency, the severity, how long it went on for, but the degree of physical violence and bodily violation is also important, and the level of terror or humiliation that was involved, because that leads on to long-term stigma and shame that is often not immediately reported or revealed by the young person. The persistence of that threat in a real or a veiled way. But the other thing when you think about it is, going back to the road traffic accident, if two people were exposed to that, if on the one hand, a parent was there that was able to take the child to the emergency department and be with the child when they're having their treatment, that child will be much less affected by the traumatic event than the child whose parent was also injured in the trauma or hadn't been in the car with the child. They were traveling with a family member or a friend's parent, and they're brought to hospital without their parent, without their support giver. Research has even found when you look at children who've had severe burns, and children generally get pain medication, maybe morphine, when their burns are being changed because it's so painful. If that happens with the parent present, a child will need much less pain relief than the child where those burn changes, the dressing changes are happening without the parent. So going back to that social support and attachment, that is so important in terms of buffering the exposure and experience children will have from trauma. And lastly, factors within the environment, the immediate reaction of the caregiver and those close to the child. If a child has been physically or sexually abused at home, and if they tell their parent, the other parent, or if they've been abused by a neighbour, if the parent immediately comforts the child, safeguards the child, wants to make sure that this abuse is investigated so that it doesn't continue, that child will experience far less trauma than a parent who is questioning, who is doubtful, who's not believing, or in worst case scenario, is aligning themselves with the abuser, perhaps for their own emotional needs. Some of this I have mentioned, the quality and access to constructive supports, and that includes both family but also therapeutic and professional supports, the degree of safety afforded in the immediate and subsequent aftermath, prevailing community attitudes and values, and cultural and political constructions of gender, race, and sexual orientation. So when you think about a child having experienced trauma, and you think of them in the school environment, traumatized brains are just not able to learn because the connections have been severed or dysregulated. A child may have physical symptoms that are distracting them in school. They may be dysregulated, unable to control their emotions, daydreaming, disengaged. They can't sit still. They have difficulty retaining any information because they're all the time scouring for that threat or trying to process what has happened to them. They may act inconsistently or impulsively. They may be very resistant to transition or change because that had created some sense of safety for them. They may be unpredictable reactions to reminders of the event that are not very obvious to teachers. So a child coming in wearing a red Liverpool t-shirt might have been the t-shirt that their abuser had worn, and the child might suddenly react in a way that is inexplicable, apparently. They may be thinking others are violating their personal space. So somebody is looking at them in the classroom, they may challenge that very aggressively. What are you looking at? Or if somebody brushes against them in a line for the canteen or the bathrooms, again, they may react physically because it's an automatic survival instinct response. Over or underreacting to the bells in the classroom, moving from one class to the other, slamming of doors, or sudden movements. It's important that clinicians who are involved in assessing young children and supporting young children, that we also consider trauma when we are faced with children who are presented with having learning difficulties, attentional difficulties, or dysregulated mood problems. Going back to that concept of adverse childhood experiences, and this has really come to light in the last couple of years. It was initial seminal work that had been done in the late 90s in America by initially an adult physician engaged in managing morbid obesity and beginning to recognize that many of the people who had lost a lot of weight put it back very, very quickly. And when questioning why, the reality was that overweight and morbid obesity had become a protective factor for childhood experiences and traumas that they had had. And that led them to do a survey and recognize that a huge number of their adult patients had had adverse childhood experiences. And when they followed them on into adult life, they found it was linked with a significant number of physical and mental health difficulties, also poor school performance and poor work and employment. So in children, surveying children in America, ACEs, as they're referred to, are very common, occurring more than 10% of the classroom having 3 or more ACEs, and about 60 to 70% of children having at least 1 ACEs. These were a list that included some of the initial 10 that Felice and his colleagues collected, and then moving on, the understanding is it's not just the number of adverse events you have, it's the salience for them, and it's also the repetitive nature, the qualitative component of it, and the meaning that the child takes from them. We know there's a cumulative negative effect from adverse childhood experiences. Ending with the treatment, it's important that all of us observe and identify and treat trauma early. Treatment doesn't mean erasing the trauma, because we can't, it happens, but it helps the child cope with the trauma and build a narrative around it. It helps build resilience. And treatments involve just support from parents can be considered a treatment. I'm referring to treatments in the broadest sense, and it includes treatment through schools, societies, clubs, and if required, specialist treatment. You can do a bottom-up approach, and again, Bessel van der Kolk talks very much about the importance of the body needing to feel safe, because in that traumatic period, our body, our physiological arousal becomes an unsafe reminder of trauma. So everybody can encourage children to ground themselves, to become involved in body-based therapies, whether it's professionally or not, yoga, mindfulness, relaxation, breathing, moving, dance, song, theatre. There is a growing evidence base that all of this are helpful in post-traumatic stress disorder and other traumatic situations. An example is, many of you might have heard of EMDR, which is eye movement desensitization and reprocessing, where somebody is helped in a professional way talk through a narrative about the trauma that occurred whilst they are focusing on some body movement that's very concrete, like moving your eyes from side to side in response to either a pendulum or a finger, or tapping something side to side, connecting both parts of your brain, whilst this narrative is allowed to be replayed, reprocessed. The hippocampus forms new memories, and that is connected with the cortex when the amygdala has been shut down sufficiently to allow that normal connectivity to take place. A lot of work suggests that in serious traumatic events like post 9/11, in hurricanes, in conflicts, that encouraging groups to get involved in EMDR can be very helpful. The top-down approach then refers to our cortex and our thinking brain, and helping the child think a little bit more about those traumatic events. If psychotherapy is part of the work, it helps the child speak, draw, play, write about the trauma. In cognitive behavioral therapy, it helps the child to manage their fears, examining their thinking, belief systems, and recognizing dysfunctional or negative or automatic belief systems, and being willing to challenge them a little bit and experiment that and reflect on how that went. Trauma-focused CBT helps them reprocess the trauma in a safe environment. And therapy for PTSD is almost always including a parent or another person who takes care of the child. Medication has a role, a very small role, in a very small number of children, whether it's antidepressants if there's anxiety or depression, or hypertensive medications which calm down that physiological arousal. Trauma-informed care refers to how all of our services, whether it is clinical services in psychiatry, whether it's GP services, whether it's going in to have your foot operated on, that clinicians need to be aware that a huge number of individuals are exposed to past trauma and that our services must not re-trigger or re-traumatize them. And if you think of particularly a medical setting, when you go to your GP or you go to the hospital, the first thing you do is you take off all your clothes, you lie on a bed, and there's a complete power imbalance between you and the clinician, whoever they are, who is providing you with the service. And we need, as clinicians in that service, to be far more aware of the potential for that to re-trigger individuals and have a service that is much more designed around trauma. There are 5 key principles. Services must be safe. They must be trustworthy, where they are transparent in the work that they do. There should be choice, where the patient is allowed shared decision-making and where we are listening to their view. Collaborating, validating their feelings and their wishes, and cultural considerations. Historical trauma should be recognised and addressed, and again, as before, race, ethnicity, sexual orientation, age, religion, gender identity, geography should be explored and incorporated within organisational structures. Thinking about educational places, whether they're schools or universities or training centres, again, there are 3 pillars from the trauma-informed care: assisting and helping young people manage their emotions, connection with that individual, and ensuring the environment is safe. To end with, what we need to do is change the narrative. Instead of saying, what is wrong with you, when we see children, our own children, our students in school, our clients that we see, our patients, instead of saying, what is wrong with you, we need to ask, what happened to you? But equally important is who was there for you, because it's that protective network from parents, from that support system that has started as the attachment, that can really be protective from subsequent trauma, or might need to be re-bolstered, re-supported, re-energized in order to help a child cope with past trauma. There's a number of very interesting books that you might like to read. I have listed them there. The Body Keeps the Score. Gabor Mate also writes about When the Body Says No, and what happened to you is also important. And maybe a much more rich resource is the National Child Traumatic Stress Network in the United States. And if you don't like reading, if you prefer to listen, there are many, many YouTubes out there that will be very informative. I'm sorry that I amn't able to take any questions on the webinar tonight. I hope you have enjoyed attending. I'm delighted if you want to look back over the slides, they'll be available to you. And I'm so grateful to Cycle Against Suicide for the huge work they're doing in working with parents, with teachers, in promoting mental health for all. Good night, everybody. Go raibh maith agaibh, go léir ag éisteacht.
Fiona, thank you. What an incredible webinar. We want to thank everybody for showing up tonight, and we will see everybody again on the 5th of December. Thank you. Take care. Good night.